Hello, everyone. Happy holidays. Thank you very much for coming. Welcome to our December issue of the Sports Acupuncture Webinar Podcast. My name is Matt Callison.
I'm Brian Lau.
Thank you very much for coming, you guys. And thank you for the American Acupuncture Council for inviting us here. We have a very special guest today, Ian Armstrong, who's on faculty and the teacher of the postural assessment and corrective exercise class that we have in the Sports Medicine Acupuncture Certification Program. Thank you, Ian, for coming.
Thanks for having me.
Thanks,
I've been watching you guys do these type of podcasts here for a few times, and I'm excited to join.
All right, awesome.
Great.
Can we go to that first slide there, please? And we'll go ahead and do a little overview of what we're going to be trying to accomplish in this very short 30 minutes. All right, so a quick overview, and this is playing off of the blog article that Brian and I wrote on the Sports Medicine Acupuncture webpage. Exercise prescription for the acupuncturist. In particular, it's for when you have a patient with medial knee pain, a few different things to take a look at that can really end up helping quite a bit with your patients. And we're talked about an elevated ilium and the muscle imbalances and the sinew channel imbalances that can end up causing the knee to move in. So we're going to be speaking about that and also what can happen with pes planus. So, let's as a reminder, just something about this exercise prescription is that we feel that the exercise prescription is a very important adjunctive therapy for acupuncturists to use. It's just as important as prescribing herbs or dietary recommendations. And exercise prescription is not only just for postural imbalances and orthopedic rehab, but there are also many exercise prescriptions that are exercising muscles that stimulate the front mu and the back shu points, as well as Shiclef, Luo, and Jing-Well points. So it's important that we are exercising certain areas, even for Zongfu components, for example, like upper jiao, asthma, or even post-COVID patients. How wonderful it would be to actually give them some exercises that gets their rib cage moving and such. Mm-hmm. And I know Brian has a few comments on this as well, so I'm going to hand it over to him.
Yeah, I think just to parallel that, the space, if you think about the whole chest and the abdominal cavity, you want a space in there for things to circulate well and move well. So if there's a lot of collapse in the chest, well, that's going to put a lot of pressure on the lungs. And the diaphragm, if it's pushing inward, that's going to put a lot of pressure on the liver. So to have really good just circulation through the abdominopelvic and through the thoracic cavity, corrective exercises, Qigong, Tai Chi, all of those types of movement exercises, which is a big part of the tradition of Chinese medicine, is really essential both for, like Matt said, orthopedic conditions, especially, but for really any condition, just to have proper circulation and proper movement throughout the whole system.
Mm-hmm. 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 Great. So then let's go to the next slide. And Ian, do you want to go ahead and start with this and walk us through?
Sure. So when we're looking at some contributions to medial knee pain, there's a couple of aspects that we've got to look at. Often the knee is really the joint that's just caught in between two other joints that have a lot of range of motion. They can have a lot of propensity for deviation, both standing or statically and through movement. So in the PACE program in SMAC, we look at both movement assessments and static assessments. And with these two joints that I'm speaking of, I'm talking about the hip and later on as we'll get to the ankle and foot. So in the first picture, we can see the gentleman here standing here with a plumb line down the center of the body there. And you can see on his right side, even a little bit more without having any palpatory confirmation, you can see that that right side's got a little bit of elevation. You might be able to see even a little bit on the, if you're comparing the distance between the side of his body and each hand, you can see that there's a little bit less on that right side. You can see a little bit of a fold on that right side, and you can almost tell that there's a little bit of elevation of his right ilium there. Moving to the picture in the middle, we can see as a practitioner, it's always good to confirm what we're trying to see with palpation. You can see Matt's got his hands over and on top of each iliac crest. And again, with this different patient, we can see that this person's also got an elevated ilium on that right side. And then we can confirm these what will happen with these deviations or the imbalances of the myofascia and the sinew channels, and how it's going to affect the movement. So in this case, we like to use the overhead squat. It's often used in the National Academy of Sports Medicine, or NASM. It's also a big movement screen that's used in something called selective functional movement assessment, that uses a lot of movement screens to try and help with pain and increased performance and function. You guys got anything to add to that?
Yeah, I do. For the actually two things. For the middle picture, of course, it's a nice chance to see an elevated ilium again, but also it really gives you a good picture of how to assess the elevated ilium. Now that Matt is kind of moving off to the side, so you can't see through Matt, so he's moving off to the side so you can see his hands. But if you were really assessing and there was no need to take a picture and he was right behind the person, the goal is to get your hands really at the top of the iliac crest, not just come in and feel bone, because you might be in a slightly different place with each hand, but to kind of crawl up until you sink in just above the iliac crest, sink into the area where it's a little softer, where there's no bone underneath your hands, and come down on top of the iliac crest. And the finger position really tells you if one hand is higher than the other. So that's really showing the proper assessment, or a good way of assessing it.
Very true. I think it's common to kind of miss that top of that iliac crest. It can hide from you. So sometimes I'll even like to start at the rib cage and palpate down until I feel I'm in definite space, and then, as you can see, Matt's using his hands like levels that are really distinct, landmarks of each height of each crest, and that's really helpful to get that clear, distinct mark, and then just to get right at eye level with it when you're assessing.
Yeah, you should be able to see it, but it's good to confirm with your hands, because sometimes maybe just a little bit of the adipose tissue sits on the structure in a way that can confuse you, or the pant line can confuse you, or something like that. So the palpatory assessment is really key. If I could add one more thing, I'd like to see if Matt has anything to add too. And this is the last thing we'll say about this, because the rest of it will be a little bit more on the biomechanics. But the person on the left, of course, has an elevated ilium. We could look at the musculature, the quadratus lumborum, and stuff we'll talk about as we progress forward with the channel sinews that are involved. But if you kind of just think past the muscles for a little bit and think, well, his kidneys would be moving along the psoas muscle. So what's happening with the position of the kidney on the right, or the liver? The liver can have a range of motion that it does as you take a breath, or as it slides in relationship to the stomach and the kidneys and all the organs. It can be complex, but maybe that internally that liver is stuck down to the kidney or to the intestines and isn't able to sort of move freely. So he has to position himself in a way to sort of free and take pressure off that liver. And that's what we were alluding to in terms of the internal Zong Fu can really be affected by posture in a lot of different ways.
Absolutely. Pelvic girdle, any kind of pelvic inflammatory diseases, or anything actually when you look at the Zong Fu with an elevated ilium. So let's zero it back into the medial knee pain. With all orthopedic examinations, the practitioner will be thinking about what channels are affected in excess and deficiency, and therefore you can start figuring out what points to be able to use. So this is a good segue then going into our next slide. Going into our next slide. All right, awesome. All right, so here it's going to be taking a look. You'll see frontal plane muscles of the hip abductors and the hip adductors along the gallbladder sinew channel, and also the liver sinew channel. So when you have an elevated ilium, you can see that the hip abductors will be in a lengthened and relative deficient position on the side of the elevated ilium. And then the adductor muscles, the adductor muscles, will be locked short and a relative excess. Why is this important to know? Because it's going to predicate your needle technique at the motor points of these particular muscles. So on the opposite side, you'll see where the ilium is on a lowered position, that glute medius and minimus on the gallbladder channels in a locked short position, pulling that ilium downward. And then you have the adductors are going to be in a deficient locked long position. Now these are only going to be in the frontal plane. Now these muscles themselves are going to be directly indicated with elevated ilium. And as the person's going into an overhead squat, what you'll commonly see is that knee moving inward. Now, there's also other important muscle that we're going to be talking about on the urinary bladder sinew channel. Ian, do you want to go from here?
Sure. Great explanation. I think through the wonderful artwork on the left side and then seeing the visual of me in an overhead squat on the right, you can see how the excess adductor can be pulling that knee moving it in, and the inability or the inhibition of the gallbladder sinew channel on the glute medius and minimus to properly support that knee and keep it stable. However, there's other things that we've got to tease out of this because it's not going to be the only culprit, or it can be other things obviously that can cause that knee to move in. Again, we mentioned the ankle, which we'll get, and foot, which we'll get to later, but also even looking at other kind of muscles that are attaching to the hip and the ischium, for instance, is the lateral hamstring group. Now we know that the lateral hamstring, specifically the long head of the bicep, is a biarticulate muscle, meaning it's going to extend the hip and it's also going to bend the knee. Therefore, it's going to cross that knee joint. So if you can think of it as the string on a bow and the leg being a bow, and how if that string is tightening down, that leg is going to not have ability to keep straight, and it's going to start to collapse that knee to move inward. So there's other variations of this overhead squat that we would use to try and tease which one is being a culprit. They could both be contributing to that need to move in. But we learn different variations of this overhead squat to try and tease that out to see if that lateral hamstring group is really contributing to the tightness and not allowing that knee to keep straight and pulling that knee bow in. So that would be your urinary gallbladder, your urinary bladder sinew channel.
Brian, you want to comment on that?
Just to add to it, that could of course be in the same way that Ian described. That could be the lateral head of the gastrocnemius also, and for that matter, peroneus longus. That whole urinary bladder channel on that side. And again, just like what Ian is saying, those both cross the knee. Gastroc coming from above, hamstrings coming from below. So if you think of the whole channel from the hip to the foot, as Ian was saying, you can see on the lateral side that bow, that line is shortened, creating a bowing of the knee, versus the more medial hamstring and medial gastroc. So it'd be relative excess on the lateral side.
Right.
All right. So good. So just as a reminder for everybody, what we're describing right now is zeroing in on one postural dysfunction that can cause medial knee pain that's useful for the acupuncturist to assess. Now, looking at the biceps femoris, that lateral hamstring being in an excess position, and what we already covered with the hip abductors and adductors being excess and also deficient. So that's going to be important. Now, we also have to look at the constitution of the patient, right? So if we have our assessment, we do our tongue, our pulse diagnosis, we figure out who is this patient with this medial knee pain, and perhaps maybe actually have liver qi stagnation or liver yin deficiency as well, where that organ is also contributing possibly to some of that medial knee pain in addition to these postural dysfunctions. So we would be developing our acupuncture treatment plan and protocol, which we don't have time in this particular podcast or webinar to go over. But after the acupuncture and a balanced acupuncture treatment, and then doing your myofascial release techniques or cupping or gua sha and such, everything that we do as acupuncturists, you're now priming the body for exercise prescription. And this is really no different what our founding fathers have done before with acupuncture, and I'm sure teaching Tai Chi exercises, movement patterns, and Qigong. We're just describing it in Western biomedical terms. So therefore, let's go ahead and discuss a really excellent exercise for lowering an elevated ilium after the acupuncture treatment, which would be in the next slide. And then this would be a nice little segue also for Brian. If you want to get ready for the demonstration, we've got a little treat for you. Brian's in his office and he's going to be demonstrating some of these exercises for us. So let's introduce them first. The exercises, what you're going to be seeing. So here on the slide on the left, you see Ian on a figure 4 wall. So his right hip is at 90 degrees. And on his left ankle, you see that lateral malleolus over extra point Hayding. So he's going to be pressing the knee outward in order to work on the hip. The hip abductors are going to be contracting and the hip adductors are going to be relaxing in this case. So you could see on the side of an elevated ilium, if you put the person into this particular position, the locked long deficient hip abductors on the elevated side are now contracting isometrically. Now, this is after your acupuncture treatment, so they're really primed and ready for this. You've treated the adductor muscle with the reducing needle technique, and now the adductors in this particular position are being reciprocally inhibited, so it's complementing the acupuncture treatment. Now, if the person has lack of flexibility in this particular position, there's a number of different sequences that we can do, which Ian, do you want to follow up with that? And just briefly just describe it, and then we'll go right into Brian so he can show it.
Sure. So, I mean, great description of me on the left there. When we're looking at, these are other variations of what we would call figure 4 exercise. So you can see someone else here on the right-hand side being able to add a little bit more of a rotational type of movement to, again, as Matt was saying, contract and stimulate the contraction of the gallbladder sinew channel with the adductors and getting that release and stretch of the adductors, again, which will especially be profound and effective once the treatment has been completed. I imagine we're pretty ready to move on and see Brian here, because I would love to talk about some of the nuances of these exercises and the keys to really making sure that they're effective.
Yeah, let's go to Brian. Awesome.
Great. So as you can see, Brian set up here, he's got his hips flexed at 90 degrees. He's got his knees flexed at 90 degrees. It's hard to tell from this angle, but we really want to make sure when someone is up against the wall like this, that their starting position is neutral with their feet. And by that, I mean, they're not abducted, they're not adducted with their feet. And as Brian's just demonstrating now, they're all aligned north-south or superior to inferior. So you don't want to have that movement of the misalignment of the feet. It's important to have those nice and aligned and together, in line with the hips. So running with the two examples, meaning we saw on the first slide and in the second slide with the artwork of the musculoskeletal system and the imbalances of the muscle groups, let's say that Brian had an elevated right side. So it's nice you notice when you're looking at the exercise in the photos before, you saw that obviously we're addressing one side. It's not a bilateral exercise. You're addressing one side at a time. So when it comes to giving this exercise to your patients, I think it's nice to obviously have them do both sides, but also it's important to have them give a little bit more attention to that elevated side. We want to get more activation from that deficient gallbladder sinew channel of the glute med and minimus that are elongated and lengthened and inhibited by that elevated ilium. So we'll have him start with his right ankle. We're going to have him go ahead and put his right ankle over his left knee, just like so. You can see that lateral malleolus even with Hayding. We want to make sure that his right foot is generally flush with the outside of the thigh. And it's a good marker, so he's not too far over and crossing. Beautiful. And then he's going to go ahead and abduct and externally rotate that hip and push down just like so. And when we're going through this exercise with the patient, we want to make sure that they're not compensating at the hip and seeing that hip elevate. I know if it's hard, for those of you who are watching, you can kind of see what he's doing through the mirror there and get an idea of how that compensation can often be had. With these postural exercises, they don't seem too difficult, and they aren't. But the thing about them is when we have these deviations for a patient, it's often that they are used to moving their body to get out of the crux and the importance of and the effectiveness of what that exercise is trying to do. So paying attention to these little deviations or wiggles and how they'll try and get out of doing the exercise properly is really important to pay close attention to.
Hey, Ian.
So
yeah. I'm sorry for interrupting. You're probably just about
Okay.
to say it, but I just want to make sure that we do cover it. Some patients, right, as we know, have a difficult time getting into that figure 4 because of tightness in
Correct.
the hip. What would you instruct to do?
That's a good one. Beautiful, Brian. Yeah, exactly. He just can't get there. Or maybe he can get there, but there's so much deviation at the hip, that hip starts to really tilt up that's no good, right? That's not going to be effective. There's no way that they can get out of that and get into proper alignment. So what we really need to do is decrease the angle of the leg that's not being stretched. So in this case, it would be Brian's left leg. We're going to go ahead and have him decrease that hip angle. So meaning that taking down that 90 degrees of hip flexion and really trying to make sure that we can give proper space for whatever their flexibility is to get that right ankle back over the left knee. So and then being able to abduct and externally rotate that hip, being able to stay put, that transverse plane, if you will, through that hip is not being deviated away from, and we're getting a nice activation of those abductors, the gallbladder sinew channel, and that openness and the release of the adductors and the liver sinew channel. Mm-hmm. So should we maybe move on to the rotational?
Sure. And once the person can able to graduate from these particular exercises, and we'll go into more an exercise that the person needs to have more flexibility for. So let's take a look at that one.
Yep. So now Brian's in a position called a hook line position. You can see that the soles of his feet are on the floor. Typically, I would say that I like to have about 90 degrees of knee flexion. So he's a little bit more than that right now. That's okay. That's something that's actually sort of custom to that patient. Again, you can decrease or increase that angle depending on how flexible they are. For instance, if the person is not so flexible, you can lengthen that there you go, just like that, Brian. So obviously you can see that knee's coming down. It will be easier for that patient to put that ankle over the knee. And then if they're not getting enough stretch, you can increase that angle too, right? You can go the other way. So going, up just like Brian did allows that increase and maybe more of a stretch if that's what they need, depending on the patient. So once they've found that right angle, you're gonna go ahead and take that right ankle over the left knee. Again, making sure that the ankle, that left foot is flush with the outside of the thigh. He's gonna go ahead and let that whole sole, that right foot to be on the floor. So he's gonna go ahead and rotate over. So that whole right leg, outside of the leg, that peroneals, that the IT band, all of that's flush with the outside of the floor. He's going to go ahead and dorsiflex and activate that right foot. So you can, I don't know if you guys can see through the mirror, but he's flexing that right foot that's flush with the floor. We want to make sure.
Can we have Brian go to the other side so we can see that?
Sure. Good idea.
Oh,
yeah,
yeah, there you go.
So he's flexing that right foot now that's on the floor. The left sole of the foot should be able to stay on the floor. So if that's not being able to stay on the floor, then what we need to do is decrease the flexion of the hip angle, just like we showed in the beginning. That means he's probably too steep of an angle and it's too much of a stretch. So just like the figure 4 wall, he's going to go ahead and externally rotate and abduct his left leg. And we haven't really discussed that too much about the time. So he can hold for this for about 30 to 60 seconds. I really also like to give a cue for the patient to really reach with in this case, this would be for Brian's left knee. So kind of reaching that towards the mirror will sort of elongate that area and give more of a stretch. Sometimes felt in the TFL, sometimes even felt more in the quadratus lumborum, which is also on that liver sinew channel. So this one, in regards to its difference with the figure 4 wall, I think sometimes patients can feel more of the stretch moving in through that liver sinew channel up through that quadratus lumborum. You can also, if he's comfortable with it, go ahead and rotate his head towards the leg that is being activated. So that left side for him, as you can see, he does that through the mirror. So I feel like that elongation can really feel all the way up through that necessary. Because as we can see, we didn't see in the artwork that the elevation of the ilium is also going to cause shortened quadratus lumborum on the ipsilateral side.
This is excellent. Yeah, we're running short on time, so we're going to have to cut that one. This is also, it's all right. This is great. This is really good. For step-by-step information on this exercise, we have that in the blog article on the sportsmedicineacupuncture.com. It's the December blog article. So let me discuss a little bit real quick what we teach in the PACE class. PACE is an acronym for the Postural Assessment of Corrective Exercise. We talk about intradermal needle using Pynex needles on extraordinary vessel points to be able to increase the range of motion and decrease pain. For example, if you had somebody that was in this figure 4 position and they had some hip joint problems, or let's say some discomfort in the hip abductors or so, you could use a particular master and confluent points to help decrease this so the patient can stay in that position and perform the exercise successfully. So now what you're about to see right now, a particular master and confluent points. I'm not sure why there's feedback happening right now, but anyways.
I think it's the beginning of the video.
And, let's go to the next video, please. Now what you're about to see right now, a particular master and confluent points. This is from the PACE class in a Chicago SMAC class, what you're about to see.
What's happening? So I have posterior left hip pain when I go into external rotation. It's quite painful. It fatigues very quickly. It's difficult for me to even get into this position. Hold, and I'm in pain right now. Here.
Okay, we'll get out of it.
Yeah, okay.
Ready? Okay.
But the other side of that.
This is the one. All right, so let's play with this. This could be a number of different.
Yeah. Very tender.
Do you, however, when I do this, I find myself, are you
Making sure that it's so get in the proper position. We might have to do more. Okay, but let's see how it goes. Okay, are you able to do it?
Yes.
That's pretty cool, isn't it? Are you getting this? Okay, let's keep this rolling. This is really good. Hey, you guys, this is a really good one. You guys ready? Okay, this is a really good one. Okay, what the problem that she was having is just getting into this position. She was feeling a lot of pain in the glute medius minimus, and it was fatiguing. She wanted to actually get out of this position. So that movement is actually pretty complex, isn't it? It's rotation, it's extension, hip abduction. So we went ahead and did gallbladder 41, Sanjiao 5 on both sides. And she's now able to do the exercise and stay into this position. It was really quite an interesting face that she had. It was a lot of surprise. It was good. Okay, so if that one didn't work, we would have used probably Du Mai Yang Chow or Ren Mai Yin Chow to be able to see with the extension and the abduction. You guys good? Good. Making sense?
It was the points on the unaffected side that were most tender too.
That's good to know.
We did all four. But
Yeah, so the unaffected side were the most tender. All right, good job, you guys. Keep going.
Thank you.
All right, let's go to the next slide, please. All right, so what we're using are the Pionex needles by Saren. The distributor for that is Los OMS. Los OMS is the sponsor for the Sports Medicine Acupuncture Certification Program. That's the size needle that we normally like to use. People, it will stimulate the receptors enough, the extraneural vessel master and confluent points enough, and it's usually painless for the patient when they're doing exercises. So I know that we've gone over time, everybody. I really apologize, but we only have like 3 or 4 more slides. So let's go ahead and finish this up. Let's go to the next slide, please. Ian, you want to take this over for the biceps femoris?
Sure. We've just got a couple examples here of some good bicep femoris stretches. Again, understanding that with its biarticulate nature and how it crosses the knee joint, it can be a culprit for that knee moves in as well. So, there's a variety of different ways to address the bicep femoris in terms of trying to get it a little bit more lengthened and not have so much tension to pull that knee in, or to move that knee in. So, there's a variety of other ones, but these are just a couple examples that you can do to try and solve that side of the knee moves in from the hip.
Yeah, we don't have time to go into all the assessment for it, but there are ways in the overhead squat to change things to really tease out, is this more coming from the UB, biceps femoris, gastroc area, or is it coming more from the liver gallbladder sinew channel sort of aspects?
And it could be a combination of both, too.
Yeah. Mm-hmm.
Yeah. Yeah. Do you want to move?
Let's go to the next slide so we can see this. Yeah. Go for it, Ian.
So as we mentioned, we've talked about some of the different things different aspects from the hip that can cause that knee to move in. We can also be looking, as we mentioned before, at the foot and how it can, be a contributor to that knee moving in. So on the left side, we're looking at the pes planus, and also sort of the foot abduction being part of that issue to move that knee. The knee moves in, and sometimes even if you don't see any pes planus or from a standing posture or a foot abduction from the standing posture, when someone goes into an overhead squat, the tightness of that whole lower urinary bladder sinew channel will come to light, and you'll see that foot abduct and even maybe start to collapse and overpronate. So that would be, restriction and tightness from the urinary bladder sinew channel, like your peroneal groups, your lateral gastroc, some of the things that we mentioned that could take that and tightness and pull that knee in.
Good.
Yeah,
Brian,
A little change of subject, I guess, but a quick question popped up about the previous example. It was Sanjiao 5. There was a question of a Sanjiao 5 or 6. Sanjiao 5 and gallbladder 41. And typically in the corrective exercises, when there's difficulty for various reasons, that would tend to help with more rotational aspects, rotational problems.
Mm-hmm. Mm-hmm. Yeah. The protocol for this is in chapter 4 of the Sports Medicine Acupuncture textbook, and this is something that we also teach a lot during each one of the PACE series in the Sports Medicine Acupuncture Certification Program. Going back to this slide, let's take a look at the image on the right. Let's just put our assessment and clinician hat back on. When you've got that patient with medial knee pain, and they go into an overhead squat, and you see that knee moving inward, or possibly that foot then goes into abduction and starts to move out. That's really demonstrating a lot about the sinew channels that we discussed already, but let's look at it a little slightly different way. Is that we saw that, as Ian was mentioning earlier, that adductor is going to be in a locked short position. It's going to be excess pulling that knee inward. The biceps femoris, being part of the urinary bladder sinew channel, is also pulling that knee inward. So therefore, that also means that the medial hamstrings are going to be deficient. Now, that entire UB myofascial sinew channel, even all the way down into the foot, all right, so that lateral musculature of the urinary bladder sinew channel will be in an excess position, which I believe is information that we discussed in a pes planus webinar that Brian and I discussed in a pes planus webinar a few months ago. So you can always go back and take a look at that one as well. There'll be more information about needle techniques and such, and how to be able to lift the arch with that. So you've got a whole treatment protocol locally just to be able to treat this. And again, you're always going to try to link this to the organs, because 9 times out of 10, there's always going to be some kind of organ disharmony that the licensed acupuncturist can treat this traditionally as well, in addition to this very Western biomedical way of looking at things. Anything else, boys, or should we go on to the next slide?
Just to highlight that, Ian's demoing the overhead squat, and I don't know, Ian, if you were just doing that for the picture or if you have a tendency for the right knee to move in, but kind of what Matt was saying. Go ahead.
I was going to say it's probably both.
Yeah.
I think probably have more of a tendency of that foot to move out, and I think was probably trying to demo that knee moves in. But yep.
So just to highlight, through other assessments, we can tease out if this is more a balance between abductor and adductor, and maybe this patient has signs of liver qi stagnation or liver blood deficiency. So you're really putting all of it together. This becomes just another assessment that ties into the full tongue, pulse, questions, all of that.
Mm-hmm. Mm-hmm. Excellent. All right, so our next slide, what we're going over is one quick exercise, which I think we actually taught in a previous webinar, but is such a great exercise for that foot abduction or pes planus piece. So we've actually got 2 more slides, but let's start with this one that we're on right now. Ian, do you want to go ahead and take it over from here?
Sure. We call this inchworm in the PACE seminar series. You can also, I think, be looking it up if it's something that you want to learn about. Sometimes it's also called a short foot exercise. But the first picture on the left-hand side, that's the beginning. That's the beginning photo, or a starting position. Patient can be sitting, even if they'd like to, with their foot on the floor. Standing is just fine too. And really making sure they're getting all parts of the foot, that heel, maybe just under that big toe, and part of that, right around UB64, that part of that foot should also be planted on the floor. And what they're going to go ahead is, and you can see in the second picture, is that big toe is starting to scrunch. So what really you're doing is you're starting to get activation, and we've talked a lot about the tightness or the restriction from the urinary bladder sinew channel causing that foot abduction. What we didn't mention, and was talked about, I think, in the previous seminar that Matt mentioned through the American Acupuncture Council here, is that the spleen and kidney sinew channels are ones that we're trying to activate. And beginning of those channels, we have the abductor hallucis and the flexor hallucis brevis. So we're really trying to activate the flexor hallucis brevis and the abductor hallucis to try and get that activation and flexion of the big toe and that medial arch. So they flex that toe forward, and then they go ahead and lift and follow through. So it's almost like you're inchworming your foot, hence the name of the exercise. So you go ahead and scrunch that toe, kind of follow it up with the heel, and then go ahead and lay that toe flat again and repeat, maybe 3-4 times one way, and then actually start to crunch and push it back as well. So you would go both directions.
Cool. Yeah, now Brian's got a modification to this. Oh, sorry about that. Brian's got a modification for this one. Brian's got a modification for this. So let's go to the next slide. Brian, you want to go?
Yeah, so in this one, if you kind of see the ghost image on the top corner, that is foot abduction. So you're flattening as much of the medial arch as you can. You're exaggerating that pes planus and really collapsing that medial arch as much onto the floor as you can to give yourself something to move out of. And then you're sweeping the foot along the floor. It's not as much a leg rotation as trying to use the foot muscles to curve the foot, to make the foot like going from a long position where the medial arch is flattened to the floor to lifting and shortening that medial arch. So you're like fully contracting that medial arch and the muscles that Ian mentioned, abductor hallucis, primarily in this one, I think, and probably a little bit of flexor hallucis brevis. And then you could repeat it, turn the foot back out, flatten the arch as much onto the floor as possible, and then make one big sweeping motion to where you're turning it in.
Yeah. Excellent. Well, gentlemen, we gave a lot of information and just a super quick overview for those patients that are coming in with medial knee pain. Please take a look at the hip for an elevated ilium. Please take a look at the foot for going into foot abduction. Make sure that you are looking at the channels that are affected with this as we described. Make sure that you also are treating the patient's constitution with this, because that does make tremendous changes. And we're not just treating it locally. That's going to inhibit us quite a bit. So let's remember our roots in traditional Chinese medicine. And gosh, we went over. I'm sorry, everybody, but this is really good.
Surprise.
Yeah. Ian, thank you so much for coming on. Really appreciate you very much.
Oh, it was my pleasure. I was very excited to join with you guys. It was awesome. Thank you.
Yeah, good. Brian, you as well. It's always a pleasure speaking with you. And we want to thank the American Acupuncture Council for, again, inviting us to be able to do this. And also for next week, we've got Jeffrey Grossman coming in for the American Acupuncture Council. So make sure you tune into that as well. You guys, thank you very much. And we will see you in January. Happy New Year's. Happy holidays, everybody.
Thanks, guys.